Thanks for inviting us to present our research project. I would like to share some background information about how and why we thought about this project. In 2018, I had the opportunity to volunteer at Angkor Hospital for Children in Siem Reap, Cambodia. During this period, I undertook neonatal life support training sessions for nurses and junior doctors at Angkor Hospital for Children and in rural satellite center. I took a low-fidelity mannequin bought on eBay with me to deliver the teaching sessions. This was an excellent, enriching experience of healthcare partnership. I realized that such a partnership has great potential for mutual learning. In Cambodia, neonatal resuscitation training is provided to midwives and nurses, but this has not reached remote and rural settings. Most of the deaths in children under the age of 5 years happens in the neonatal period. There is huge disparity in the resources between the high-income countries as compared to low and middle-income countries. This is reflected in the neonatal mortality rate. Neonatal mortality rate for the UK is 3 per 1,000 live births as compared to 28 per 1,000 live births in Cambodia. Almost 3 million of all the babies who die in the neonatal period can be saved by low-tech, low-cost resources. Only 1 in 10 newborns need basic resuscitation measures, and less than 1% need advanced measures. Delivery rates in the rural remote health facility is low. Therefore, it is difficult for the healthcare workers to keep up with the resuscitation skills. They need to practice their skills regularly. This slide shows 2 labor rooms in 2 different settings, one in Plymouth and the other in rural Cambodia. They are very different in terms of space and equipment, but presence of a skilled birth attendant at delivery is the most important factor for a favorable outcome. Newborn life support through simulation using a low-fidelity mannequin can address all the components of newborn life support, such as assessment of the newborn at birth, recognizing danger signs, implementing a stepwise airway breathing circulation approach to resuscitation, and understanding human factors. And taking all this background information into consideration, we designed a collaborative research project with Angkor Hospital for Children. This was funded by Global Challenges Research Fund through the University of Plymouth. This was designed as a 2-phase project. The first phase was cultural adaptation to identify any gaps in knowledge, barriers and facilitators to providing evidence-based newborn life support and care, develop a culturally sensitive simulation training program, identify local trainers for the trained trainer program, and second phase was implementation phase to actually deliver train the training program.
Hi, I'm Stuart from 625. We're based at Plymouth Science Park in the UK. Our work is mostly in low and middle income countries with NGOs, governments and a range of universities delivering capacity and capability improvement programs. The Teachbox system that was used to deliver this project in Cambodia was designed specifically for use in low and middle income countries where the internet is particularly expensive to use from an end user perspective. In availability terms, we think about the globe having 93% coverage of either 3 or 4G network, but actually only around 48% of the globe are able to access that internet. Now, if you live in a remote or rural location, that number drops down to around 37%. Women are around 20% less likely to access the internet than men in low and middle income countries, and problems with reliability remain in most LMICs. In terms of hardware, it's expensive, it's invariably rare, which means that there's a skills gap for people operating IT hardware. In addition, there's a problem in skills terms with maintenance and repair. It's difficult to get hold of. Tablets have helped, but tablets usually have compatibility issues and can't be connected to projectors or monitors very often. Three other concerns that we had were currency. So we needed to make sure that the authoring bodies were appropriate. We needed to make sure that the content could be version controlled and not shared either peer-to-peer or platform to platform to maintain that version control. And we also needed to make sure that the tutors, the people delivering the content, would deliver all of the content and not skip the parts that they were either not comfortable with or not happy to deliver. So the system we developed is called Teachbox. It starts with Create, which is a website in which you build your course. You then publish that course out to the Teach application, which sits on the tablet devices owned by the Cambodian midwives. Both in terms of feedback and in terms of registration information, they feed back to the portal, which is shared with the sponsor organisation. So they've got real-time access to what courses are being taught, where and by who. Each facilitator is given a unique username and password with which they log into the system. This gives them access to only the content that they're competent and qualified to teach. Once they've accessed it, they need to download the course. So what we did in Cambodia was all of the tablets were taken to a hospital in Siem Reap, where all 12 tablets had the content downloaded onto them. Once downloads complete, the facilitators are able to complete the preparatory work necessary prior to delivering the course. They're not able to deliver the course until such time as all of that preparatory work has been completed. Once completed, they're able to deliver the course. The course is designed in such a way that each of the facilitators has to follow the structure in the chronological format that it's set into the system. This overcomes the issue of tutors teaching only the parts that they're most comfortable with. Each course starts with registration, in which we gather the details of the delegates. This is all fed back through the portal to the sponsoring organisation. Notice that it's GDPR compliant and, of course, attracts the appropriate consents. The videos that are used during the courses are written by clinical specialists. We ensured that they were entirely Cambodian Ministry of Health compliant. Everything was then translated into Khmer and then delivered on screen during the courses. The next slide is an example of one of those videos.
ដោយប៉ះទៅនឹងបរិយាកាសខាងក្រៅឬតាមរយៈខ្យល់ពីក្រៅជ្រៀតចូលខ្យល់រត់ចូលមិនដល់សួតព្រោះបំពង់ខ្យល់ត្រូវប្រកាសថាម៉ាស់គ្របមាត់ច្រមុះបានត្រឹមត្រូវការកំណត់ Vatios ប្រើលើទ្រូងគឺពី1ទៅ3សម្រាប់ពេលប្រើម៉ាស់សង្កត់មាត់ច្រមុះម្ដង
At the end of each video, there's some knowledge confirmation and some discussion points that arrive on the screen. The key point here is that we didn't want to embarrass any of the instructors by asking questions that they didn't know the answers to. So we built the facility where they can tap the reveal button and the perfect solution exists for them on the screen. All of the practical elements are taught directly by the midwives, so anything that's to do with hands-on patients is dealt with by those midwives. At the end of each course, both the delegates and the facilitators provide feedback. And so far, that feedback's been particularly positive. There's also a pre and post-course test, and you'll notice that there's an average of around 13% increase in knowledge reported by those tests. Thanks very much for your time.